Right. Hello, everyone. Welcome back, and it's thank you so much for joining us in this episode of Vitreoretinal Routine Business. How do I do it? So the session today is mainly focused on most of the work is routine. 95% of the work we do is routine. How can we do this the most simple way, which is efficient, time saving, and at the same time very simple. So I'd like to welcome the co-speakers here. My friends, starting with Dr. Mohammed Kenner from Asyut, Egypt. Mohammed, thank you so much for joining us.
Thank you, Dr.
And Dr. Abdullah Laban from Hull, UK. Abdullah, thank you so much.
Thank you. Hello, everybody.
And Dr. Hussein Al-Muhtasib from Bradford, UK. Hussein, thank you so much for joining us.
Thanks, Ahmed. Hi, everybody.
And Dr. Wael Awais from Egypt, Cairo, Egypt. Wael.
Thank you.
And last but not least, Dr. Mustafa Hanouk from Newfoundland in Canada. Mustafa, thank you so much.
Hi, everybody. Thank you.
Okay, well, the focus again is on how to do things the simplest way. I hope that people are seeing us now would find this interesting, particularly those who are in their first years of practice or who are in the fellowship. So we'll kickstart with Mustafa, and Mustafa is going to tell us more about issues with viewing and how to set up the vitrectomy and how to make your life easy. Mustafa?
Thank you so much, Dr. Ahmed. Actually, my talk is going to be like really basic. I just gave it a title of some life hacks to survive your first day in the retina OR. Like it's mainly directed towards starting fellows, really. So talking very basic. So like is my voice clear or okay?
Yeah.
Okay, so just some basic stuff here I'm planning to talk about. Like know your patient, know your setup, know your machines, your instruments, how to open, how to close, some simple viewing tips. I don't want to really waste time on side points, but first, the instruments. What I do in my OR is I have this booklet that actually has some description of my setup and actually have some pictures of the way I like to have my instruments arranged. And anytime, because I always have like circulating different scrub teams. So anytime I have a different team, they just put the picture on the wall and they just set my my instruments the way I like. I don't have to say it every time. But of course here, like you do the briefing before you start the case, because not every case will have all the detailed instruments. There is a basic pack that comes for all cases, but there are certain things that you need to know what you need before surgery, like if you need forceps, if you need a special heavy liquid or something like that. The other thing is you really need to know your machines. We have mainly two machines that we are relying on them like completely. We have the vitrectomy machine and we have the surgical microscope. So one of my teachers during fellowship told me that I really need to know how to set up the vitrectomy machine and how to troubleshoot, because I don't have to be under mercy of underserved place. I don't know where I'm going to work after I finish my training. So you really need to be completely independent. What I do now is I set up my machine for every single case, but this is how it is. I'm not saying that this is ideal, but this is how it is. The other thing is you need to know your parameters. You have some preference when you kick the high pressure, for example. Do you want to set it at 40 or 60 or whatever you want? What cutting rate do you like? One very important thing is the foot pedal for each machine. The foot pedal for the vitrectomy, it has to be just like your toe. You know exactly what the side kicks do, what the direct kicks do, how to switch between modes, and how to turn the cutter on or off. This you'll be doing repeatedly in every case, so it has to be absolutely seamless. The other thing is the surgical microscope. Also, you need to know your preferences. Do you need your XY to be fast or slow or average? Different things like this. You need to have your own setup, and also you need to know the foot pedal of the microscope really well, because this is you rely on it every second during the case. You cannot think during the case how to zoom in, how to zoom out, how to focus in, how to focus out, and so forth. The other thing is the setup, or like in terms of the positioning. So, for example, this is the way I like to have the foot pedals. I like the vitrectomy foot pedal at my dominant right leg, right foot, and the microscope at my non-dominant left foot. And I like to have this yellow pedal is actually to turn off the room light. Just I need to have control on that, so I don't have to keep asking people to turn on the light or turn off the light. And also, I like to have the instruments like this tray just beside me, so I can grab my trocar or grab a plug for the cannula, like the things that I'll grab myself. Of course, the other instruments, the scrub team will be helping with that. Also, like in our setup, every surgeon knows exactly how many pumps you like your bed to be, so you don't have to keep adjusting the bed every time. Just there are numbers on the wall. Dr. Hanout likes 15 pumps for vitrectomy, 21 pumps for cataract, and so forth. So the nurse come in, set up the bed for you. You didn't have to think about it. This just happens like breathing. You also need to know, do you like your cutter to your right hand, or you like to have it always temporal? It also depends on preference. And I like to have also control of the screen. Like I like to be accessible to my hand. So if I need to do something, I don't have to wait for somebody else. Now in the setup, a very important point is you have to have your hands tethered to the forehead of the patient, because this is the best way to protect the macula of the patient or the retina of the patient from any sudden movement. And also you assume the same movement of the patient. Like if you have a patient who's breathing in a certain rhythm, then your hand is going back and forth with the patient's head like seamlessly. Now some viewing tips, and I'm gonna be showing some videos as well in that part. So first of all, for good viewing, you have different like levels of media. You have to have all of them clear in terms to have good view. The first is the eyepiece of the microscope. Sometimes you can get it foggy because of breathing. You can put like a tape to prevent your breath from fogging it. You have the biome lens, you have the cornea, you have the lens of the patient. We're gonna say a few tips for each of those. First of all, draping is extremely essential when it comes to view, because if you don't drape the patient well, you'll keep getting foggy lens. The biome lens itself or the ReSight lens will keep getting foggy. So I like to cut the mask of the patient short. I like this red arrow shows the actual size of the mask, but I cut the extra part and I keep it just at the tip of the nose of the patient, so that I have large area of skin that I can stick my drape to it and prevent this fogginess. Also, I like to have this fold on the drape. It will actually protect you from having wet socks. It actually directs the infusion fluid like to the side pockets. And this is a good draping, in my opinion. Eyelashes away of the field. You have very good sticking of the drape on the patient's skin without any connection to the mask or the patient breath. The cornea, I like to use some viscodispersive substance on the cornea to keep it moist throughout the surgery. I don't have to ask somebody to keep squirting some fluid on the cornea from time to time. However, I found that if you use BSS to keep the cornea moist, it can actually give you a better view when you record videos. But I think for routine work, if you have viscodispersive material on the corneal surface, it will actually save you a lot of time and hassle. Sometimes if the corneal epithelium gets a little bit edematous, you can actually do a gentle massaging of the epithelium, and this is often adequate to clear it up. In extreme cases, you might need to actually debride it completely. The lens of the ReSight or the biome system, it can get foggy if you get too close to the cornea. So I'm going to show you here what happens when you get too close to the cornea. You see, all of a sudden you lose the sight from the fogginess, and also you might actually get too close that you actually touch the surface of the cornea, and then you have to remove the lens and wipe it. It is another case. If I come close, the lens fogs. If I just raise the microscope up a bit, you see the fogging just clears up. And this was a case with actually bad draping. So it was extremely frustrating during the surgery to actually get it done. And I was thinking midway that I need maybe to just close the eye and re-drape and then restart the case again. But I just added some steer straps to prevent that. Now, avoiding the lens touch. To maintain.
Can I just interrupt you here just to have some discussion?
Yes.
So Abdallah, do you do anything else with draping? This is a very good point, and I think cutting the mask and drape and like sticking the drape more is a great idea. I've never thought about it. That's a great idea. I do something different. I put a stay strip nasally, and I use an anti-fog liquid on the lens that they use for endoscope. Someone in Manchester in Sheffield published that. Do you do anything different
nice.
about it?
No, actually, I do exactly the same. I strict draping, especially on the nasal side, just for the air. We normally put it in the patient, and sometimes the patient hold it with his hand. We don't normally connect it to the mask. We just the patient put it in his body, and sometimes we stick it with the steer strip or a tape. And yeah,
But do you do anything different?
I mean, I agree about the nasal part, and I liked the idea about the bed positioning, that that your assistants know how many movements of the bed, that so you don't repeat that. Now, I use also, as you said before, the anti-fog liquid. It's, to be honest, it's quite helpful, especially when you're going to go for a longish type of surgery. The anti-fog works. It just keep it as standby in cases that even with optimal, like, let's say, draping, sometimes you get that fogginess. So the anti-fog liquid is quite helpful, to be honest.
Yeah, it's called Fred solution. Well, you want to say something?
Fred solution. Okay.
Well, yes, I use a fan in the operating theater. A fan which is brought close to the microscope to my place of work. The irrigation, that air current that goes through and through, helps in removing the fogging without the need to redrape and the cost and the economics in that. So we use that Egyptian idea to use the fan brought close by and to continue my work even if I'm close to the fire.
Yeah. Mustafa, please continue. It's just the fan, sometimes infection disease in some areas do not allow it.
Yes.
Yeah.
Exactly.
Yeah, these are really great tips. So for the lens, no, we did that part already. So it will have a clear lens if you're operating on a patient who is phakic. Then any lens touch, you will lose the lens during the case, and it contradicts your idea of actually maintaining the view. So my tips here. But Dr. Salami, and if you forgive me, I stole this from you actually. During my training, I was only instructed to avoid crossing the midline, so I have to switch hands if I'm operating on a patient who is phakic. But you actually, in a previous session, you said that in a very nice way, so I want to actually use your own words. So you said if you're working at 6 o'clock, and let me stop the video here. If look at my cutter, my cutter here is at 6 o'clock. So if you're working at 6 o'clock, you don't cross a line that passes across the fovea. If you're working in the center, then you don't actually pass the equator.
Yes.
And if you're working superiorly, then your limit is when your two instruments meet each other like this. So these are actually, I stole this from you indeed, but it's very useful. But actually, I have a diagram that I created that actually shows how this is worked this way. So this diagram here, you have the light pipe and you have the cutter and the eye. You're working in the posterior pole. You're away from the lens. There is no issue. If you move your cutter in a way that it is reaching at the equator, you still have some sort of a distance between the cutter and the back of the lens. You're still a little bit in the safe side. If you cross the equator, the cutter is now too close to the lens, and the risk is increased. But actually, what I believe is actually makes the risk a lot higher is if you rotate the eye. If you rotate the eye, then you're bringing the lens even much closer, and actually you bring it. You're increasing the risk of hitting the back of the lens. So I think we shouldn't do that.
Mustafa, this is a great point, really. So when you superiorly, you can shake hand with the other instrument, but you always need to sneak from the periphery of the lens. So the way I was taught is that when you're working periphery, always go peripheral, because the lens is like this, and you want to be like along the flatter part. But very nice diagram.
Should I move on to the next?
Please.
Also, a very helpful tip that I found that really works when I operate on a diabetic patient with the crystalline lens, and I expect to have a long surgery with all the like peeling and so forth. I like to use 50% dextrose solution. I inject 3 cc's of this solution into the infusion line, and I guarantee you the lens lasts throughout the surgery. Even if it's a lengthy surgery, you have to do a lot of maneuvers and peeling, and takes like an hour and a half or something like that, but you still have your lens. It takes you throughout the surgery without losing the lens. I found this to really work almost all the time.
So that's in phakic diabetic patients.
Phakic diabetic patients, yeah.
Any tips to maintain the cornea transparency?
I'm sorry?
Any tips for the corneal transparency in diabetics?
I don't do anything different for the cornea in diabetic patients, but if you have something, I would really appreciate it if you have like any special tip for that.
No, I'm not sure if the 50% dextrose makes any difference when it comes to the cornea. Or is it only like it affects only the lens?
I feel it affects the lens mainly. I didn't really find any issue with the cornea in diabetic patients, even if I'm not using the dextrose. But I feel that if the surgery is lengthy in diabetic patients, I lose the lens sometime, like after maybe 20 minutes or 30 minutes. Also depends on the sugar level for the patient. But I really found the dextrose solution to be very helpful if you add it to the infusion.
I think you lose the cornea in these cases if you have a high pressure, like for a long time during the surgery.
Yes.
You get a lot of bleeding during the surgery, and you raise the pressure and forget about it, and then the cornea is limited.
So that's a very good point, Ree. When you put
that's
the
a good
pressure
point,
high,
yeah.
when you're cutting, it's not only
Right.
the ischemia that may happen. If you keep it too long, you can lose the cornea. Sometimes we forget it. And you
That's
can
right.
get edema. If you remove the epithelium in diabetic, one tip is always remove the periphery and put a contact lens. They may heal badly. And I had a patient before who had really significant cornea scarring necessitating PRP. So always leave a little bit and fill them with a contact lens.
That's nice. That's a nice tip. Yeah.
So Mustafa, yeah.
For the lens also, if the patient is pseudophakic and you're doing like some fine macular work, you might need to do a posterior capsulotomy if it is, if you need, like if there is posterior capsular opacity, then you might need to do posterior capsulotomy at the end. I think it also belongs to talking about the lens and maintain your view from this respect. The other thing is, in starting the case, how to get your view and control it. So first of all, how to focus initially to get the best focus. So first of all, like I say, fill the lens first, and then zoom in on the disc to a high magnification, and then focus then to have a crisp disc. And after that, you can zoom out again and have your view. So these are the 4 steps. If you do, you get your good focus and you get a good initial view. But now, is that like, should I pass this point, or anyone want to say anything about
That's a good tip. You get a good difference when you do that.
Yes. The second thing, now you got the view initially, but now how to maintain your view throughout the surgery. What happens is sometimes we need to move the eye like here. So if I move the eye like here, what happens? I'm working through a small crescent. I can barely see anything. But when I use my XY in the microscope, my XY control, and I move the lens to the same direction I move the eye, then I restore the view. So the message is the movement of the eye and the movement of the microscope has to be synchronized. Like anytime I move the eye, I should move the microscope. I watch my surgeries when I was in early training, for example. I see I get out of the lens, I get out of the field like oftentimes. But now, like, it happens by the subconscious, you don't have to think about it. So you have to maintain your view. Also, what happens when you raise the microscope up? You get the field gets smaller. So you need to maintain a good balance, like the lens needs to be close to the surface of the eye in a way that you still have a full field like this, but not too close to start to get foggy. This is another point. The other thing is you need to, I don't like, many fellows when they start, they are doing like a treadmill. I call them a treadmill surgeon. They are putting a lot of effort, but they are not going anywhere. Like they don't see the vitreous. We have to know how to illuminate the vitreous, especially those in training or starting their training. You need to know how to illuminate the vitreous so that you can see it. So because many fellows, they keep aspirating BSS because they don't really know how to see the vitreous. Like, just by the way, talking about this, we need to know the objectives of the surgery. You cannot just stay in the middle of the core of the vitreous and keep aspirating BSS and not really achieving anything. This contradicts with surgical efficiency. Efficiency doesn't mean speed. It actually means to be effective. So here's my tip on how to illuminate the vitreous so that you can see the gel and makes you more efficient in actually removing it. First of all, number one tip, in my opinion, is pull your light pipe back. So I'm just gonna stop here. Here at the beginning of the video, my light pipe is back, so I'm illuminating a large area of the fundus. I have a good field here. If I push the light pipe in closer to the retina, now I'm having a smaller area of the fundus illuminated. Now, another thing, to illuminate the vitreous and to see it, the light has to be shined anterior to the vitreous. So in this scene here in the clip, the light is actually directed posteriorly, so I don't see the gel. I'm not sure, is my cursor visible here?
Yes, it's visible, Mustafa. Yeah.
Okay, so this is my cursor. So the light is directed posteriorly. I don't see the gel in the area of my cursor. Now, if I shift the light anteriorly, now I see the gel. So if you shine your light anterior to the vitreous, then you see the gel, and now it makes it easy to actually remove it. The other thing is illuminate ahead of the light of the cutter. So this is the light cone. This is the edge of the light cone. So the cutter is here. So the area that the cutter is working in is all illuminated. I don't move the cutter to the edge of the light cone and start to work in the darkness. I have to illuminate ahead of the cutter, so I see where the cutter is going. This is the correct way, in my opinion, to illuminate. And also, like here, seeing the gel makes it easier. Like now, like you see, and also when you cut towards the gel, towards the retina, not away from the retina, because when you move your cutter towards the retina, you don't apply traction, or you apply less traction, I would say. I'm not sure what you guys think about that.
Mustafa, this is perfect. I mean, you just said really what we always say to the resident or to the fellow. You've put it in a nice way. I think for the sake of time, we need to keep moving.
Sure. Yes. The last point about viewing is actually, and also another thing I stole from you, Dr. Ahmed, Dr. Salem, is when you start to switch to air, then you start to lose the view momentarily, and you need to really have faith and keep your cutter or like your instrument where you do the fluid air exchange where you believe it should be, and just wait for it until you see it again. Don't just, when you stop seeing it now, don't panic, stay there. The view will come back, and then you'll be more productive. Another important tip is to clear the air from the infusions. Sorry. So you start the infusion first, and then you let the fluid pass, and you tap it a little bit to get rid of any air. Especially if the patient is phakic and you get this air, it might give you some issues. And of course, you never turn on the infusion until you make sure 100% that the infusion is actually in the vitreous cavity. So these are the tips I wanted to say about viewing. I have like a couple of more videos about setting up like the sclerotomies. I'm not sure if the time is okay, or just we should move to something different, or
I think let's come back to Mustafa, go ahead.
Okay. So just the sclerotomies, just a couple of points. First of all, I think it's always good to measure. I used to be so keen on displacing the conjunctiva, but I'm not so much. Of course, for the infusion line, you have to do this click to make sure it is actually secured in, and it's not gonna dislocate during the surgery and you lose your infusion. I don't displace the conjunctiva now, but I used to be absolutely keen about it. Like I didn't do a single case. Like I used to think it's a sin to not displace the conjunctiva. I can displace the conjunctiva either with like the forceps like this, or with a Q-tip or something. But what do you guys think about that? Do you guys are you?
I used to do RQ Mustafa. I used to displace the conjunctiva, but now I don't do it because now I suture most of my cases, so I just don't do it.
Right.
Okay, I don't do it because I don't do it now because I just it's easier if I need to suture. It's easier to see where the sclerotomy is exactly, and if an instrument displaced and you want to put it back, it's also easier. Now to close the sclerotomies, I believe that I would never leave until I'm sure that all sclerotomies are self-sealing, and I will also dictate that in my note for medical legal purposes. So the infusion line is the last one to come off, and you have to test each of the sclerotomies and make sure that they're all not leaking. You squirt some BSS. If you squirt some BSS and you find some bubbling like this, a very nice tip is to use the 30 gauge needle to just one pass through the sclerotomy itself and one pass maybe just near it. And usually it's helpful to actually close it, and never shy of taking a suture. You will never regret a suture. The only suture you regret is the one that you didn't take. And that was actually.
How does passing a needle help?
So I think passing the needle adjusts the surface tension of the air bubble near the sclerotomy and like brought it back again to maybe push the posterior lip of the sclerotomy.
You just pass the needle without doing anything. You just pass the needle in and out.
I just pass the needle and it almost works all the time.
Very interesting. We need to.
And is the needle, do you take the plunger out?
I'm sorry, what's the question?
Do you take the plunger out, or just you pass the needle?
I'm sorry, Hussein, I didn't hear that specifically.
I mean, do you take the plunger out? Do you take the plunger out?
No, not necessarily. You can keep the. I mean, it's not. I don't actually take the plunger out. I leave the plunger in so that I'm not causing further leak of the air inside the eye. But I'm not injecting anything inside the eye. I'm just passing the needle. Like I believe that the needle pass itself helps to actually seal the sclerotomy.
Hussein, for the sake of time, we will need to move on. Can you please upload your presentation?
Sure.
Just a quick question from Michael from the UK. So Michael is asking, is BSS Plus better for phakic diabetic patients? I really don't know. I don't feel any difference. Does anyone feel any difference with BSS Plus and BSS?
I mean, theoretically it's there, but I don't think there is a huge difference.
Yeah, I'm not sure. Interestingly, most of the diabetics, even if the surgery is lengthy, they don't develop cataract as compared to non-diabetics.
Hussein, I don't see your presentation. Can you please upload? Yeah, it's coming.
Can you see it now?
Yes. No, I agree, Abdullah. We published on that recently, and and we found that actually in a very big series that after vitrectomy, diabetics are less likely to get cataract.
Yeah. I'm talking more about clouding of the lens during the surgery rather than developing cataract.
Yeah. Hussein, yes, we can see your presentation. Please go on.
Great. So, I mean, thanks. I think Mustafa, you made my life easy now because I can go. I'm not going to go again because you've literally covered most of the basic stuff. I'm going to go through sort of extra tips for success and extra tips for safety when it comes to vitrectomy, but in a vitreous hemorrhage setting. Now, to start with, I mean, you need to know where you're going, and you need to know what is the reason or what is the cause of the vitreous hemorrhage. So the first, the most important thing to start with is the preoperative. From the preoperative tips is to know the etiology. You might not know all the time what's going on or what is the reason for the vitreous hemorrhage, but it's good by the history taking, by proper examination of the affected eye and the fellow eye, and by doing an ultrasound, you could more or less know what you're dealing with. Is it PVD related? Is it diabetes related? Are we dealing with a macroaneurysm? Is it something else? So this is very important. Now, regarding the ultrasound, for me, in vitreous hemorrhage, the ultrasound is the most important thing pre-op. And I would sometimes repeat my ultrasound at my pre-op round on the day of the surgery. So even if I see a patient 72 hours before surgery and I book the patient like for 3 days later, I usually repeat the ultrasound just before the surgery, because it's your, the B scan is your eye just before. It tells you about the planes, it tells you about the status of the retina, and it tells you about when to put your infusion. So I think ultrasound is vital. So this is my first tip for vitreous hemorrhage and vitrectomies. The second thing is the etiology, as we know before, because it marks the way to go, and you more or less know where you're going. Now, the third thing to do with vitreous hemorrhage is, before you go into vitrectomy, is and also it relies on the etiology, is to know, are you going to do sort of adjuvant treatment like an anti-VEGF or PRP pre-op? And one of the most important things is to have a plan in mind before you jump in. Surgery is all about having a plan and then performing the plan, which was literally designed before, performing it intraoperatively. So things that I've learned in the UK school is, don't fiddle around, which means try to be minimalistic, do the minimum necessary, try to be effective, as Mustafa said. Effective and efficient doesn't mean that you're going quickly. It means that you do what is needed all the time, and you try to be to the point. And the longer you stay in the eye, the higher the likelihood of inadequate performance. Now, the strategy, which means that sometimes you go for the first vitrectomy in a vitreous hemorrhage patient, but you know that you're not going to sort out the problem, but this vitrectomy is going to be one out of others that will be planned in the future. So think about this, and by this, you know what is the benefit of every step, and you know beforehand that this is not going to be your first and last surgery in this patient. And also, you need to think, are we going to do a vitrectomy or a combined? This relies on the etiology. I'm not going to deal with that, because I'm going to go now to talk about the intraoperative tips. Now, infusion line. Mustafa, in his first part, he talked about the infusion line and how to make sure that you see the infusion line. My tip in vitrectomy, infusion line, and vitreous hemorrhage is, you don't have to put the infusion line intratemporally in all the cases of vitreous hemorrhage, because sometimes there is another pathology that would limit you using or putting the infusion line in that site. So feel free to put the infusion line in a different place if that is going to make your life easy, and if that is going to make you avoid complications intraoperatively. Now, the second tip when it comes to vitreous hemorrhage, and before that, I'm just going to, possibly most of the audience is sort of like junior consultants or junior surgeons, fellows in the first time. There is a great book by Paul Sullivan. He's a consultant at Moorfields. It's called Vitreoretinal Surgery. I highly recommend this book, because it's full of details and full of tips for success. Now, when it comes to the infusion tip in vitreous hemorrhage, my take-home message is, it might be impossible to be able to see the infusion tip, even with transcorneal illumination from the light pipe. In those cases, sometimes you have to have faith in where your cutter and light pipe are in. But one of the tips that you could use is so you could get the infusion hub with a forceps, try to indent. You need to make sure that you see the glistening effect of the metal shaft of the infusion line. If you're not able to see it, what you could do is to use the light pipe. So go through the infusion trocar with the light pipe. This could make your life easy, and you might be able to, with this, is to be able to make sure that your infusion line is inside the vitreous cavity. So you could switch on the infusion line with knowing that this is not going to make you this is not going into the subretinal space, and you're not going to have complications from that. Another tip is the visibility. With vitreous hemorrhage, it's all about the view, and most of the time, as I said before, you need to have faith. one of the I will go through the videos possibly to summarize all this, but one of the things that I've learned from one of the consultants is he always told me, please, you need always to see both tips at a time. So the cutter should be visible and the light pipe should be visible, especially when you are going to do a vitrectomy where the view is your most important limiting factor. And as Mustafa said in his first, it's not about a treadmill, it's not about going fast. It's about being patient and starting with the core vitrectomy, waiting for the view to get clearer, and then proceed with the rest of the steps. And I think now this is the time to go into the videos. I'm not sure if, are you able now to, am I sharing the screen of the videos, or am I still on the...
No, not yet, not yet, Hussein, if you can share the screen of the video. So quick one, so this is very good. So all agree for, especially the starting people hearing us. So Hussein, yeah, try to share the, I think if you share your screen, Hussein, and start the videos, it should work.
Great. Any feedback before I go to the videos?
No, I think I'll summarize what you say until you get the videos, and then we can ask questions as you do the videos.
Yeah.
So just a very important point what Dr. Muhtasib said, always see the tip. Don't open the infusion when you don't see it. You can press it. The light pipe is a great tip. I did not know this. It's a great tip. And the other thing, really, if you're doing vitrectomy and you cannot see the tip, is just take the lens out. And that's what I sometimes do. I would take the lens out. It's just easier than ending up with the problem.
There's a nice tip where you can actually allow a little bit of air into the infusion line. And you put the infusion line, once you see air in the vitreous cavity, you know that the infusion is inside.
Here you go. That's another great point.
That's a nice one.
Hussein, we can see your screen, but we cannot see the videos. I think if you replay them, we'll see them.
Are you able to see it now?
No, no.
Let me just see. I think it's all about what type of the desktop I'm sharing.
Will. Any other points from the panel?
I like the word by Hussein that doing less is more. Actually, in all vitreoretinal surgery, be minimalistic as much as you can. The more you do, sometimes the more you create complications or make things difficult for yourself.
Yeah, Hussein, we can see your screen now. Please go ahead.
So this is sort of a video that summarizes most of the tips. Now, number one, I mean, this is not like a very dense vitreous hemorrhage, so there is a bit of view. But what I'm saying is, let's if the vitreous hemorrhage was denser.
Can you play the video, Hussein? Hussein, the video is not playing.
Are you able to see it in movement now?
No, it's just we can see your no.
Please share the application. Share the application of the video.
That's what I'm trying to do. But okay, just give me a second. Sorry for that.
That's okay. That's okay.
Share the screen.
Select application.
So a question from Riley Sanders. Riley is my fellow. He's asking about do you sometimes change the active port as well? Where maybe I will leave you to set this up and we'll ask.
Yes, thank you. Just give me a second.
Dr. Mohammed, do you sometimes change your active ports as well?
Sorry, I'm sorry, say that again?
Do you sometimes change the upper ports where you put the upper ports?
Where I put the upper ports?
Yeah. Yeah.
I don't.
Do you change their position?
No, I usually have them, like at 3 and 9 to allow me to, reach the superior retina.
Right.
I don't change them unless
Okay, Hussein, it's working now.
Are you able to
see the videos the same now?
Yes.
So this is a case of vitreous hemorrhage. To start with, make sure the infusion line is visible. Start with both tips visible to you. Be patient with the core. So most of the cases of vitreous hemorrhage is about the view. You don't know what's going on behind, below the bleed. So spend time dealing with the part which is visible, as you can see here, and rely. Most of the time I would rely. Now with the bi-blade cutters, and with that turbulence that is generated by the cutter, most of the time you don't really need to induce, the posterior vitreous detachment, unless you are dealing with one of those cases. But what I mean is rely on the turbulence, because most of the time, between relying on the turbulence, assisting that spontaneous posterior vitreous detachment, you will be able to clear most of the gel in the core, and then you can go to the periphery and do what I used to be taught that this is like shearing the sheep, which is literally going into the peripheral gel and shearing it from 3 o'clock to 9, switching hands if you are in a phakic eye, or carrying on in a pseudophakic eye. So these are the some of the tips that you need to know when it comes to vitreous hemorrhage. I'm going to share another video here, which possibly is going to summarize. This is, for example, a case of vitreous hemorrhage in a macroaneurysm. As you can see here, the view is limited. So what you need is make sure that you see the tips. This is a pseudophakic eye, makes it easier for us. Stay in the core, carry on with the core vitrectomy. Your view should clear with time. Rely on the turbulence to assist that spontaneous posterior vitreous detachment. And then sometimes, as in this case, you might have to induce the PVD, because this is where you're going to need to have this level. And once you get successful in that, then you carry on with the peripheral gel trimming. Now, as we said before, sometimes you need to treat the vitreous hemorrhage, which means you need to clear the view for further treatment. So sometimes you just need to do the minimal job necessary. And for the macroaneurysm or whatever underlying pathology, sometimes what you need to do is to leave that for a future, possibly clinical treatment rather than surgical. Now, another tip from the last video is, yes, and especially in diabetic patients, it's not going to be long. What I'm trying to say here is, in vitreous hemorrhage in diabetics, we are talking about we have limited time to do what we need to do. So don't fiddle around trying to do ILM peeling, yes or no. No, the most important thing in vitreous hemorrhage in a diabetic patient is to make sure that you do full and adequate PRP. So if your view has got clearer, you're able to laser as quick, as soon as possible, because you don't know if your view is going to get worse after that, because what you need to make sure is that you are happy with the PRP cover you have already done. And the last video, I'm going to make it short. This is sort of an unusual case of vitreous hemorrhage in a patient with crest syndrome, scleroderma. So what I'm trying here to show you is, I mean, when you look at that, you don't know exactly what to do. And coming closer to the retina from an inexperienced surgeon or somebody who's at the beginning of his surgery, it might be a bit risky. So what you could do is try to do as much core and peripheral VT at the beginning. And my tip here is have faith in your back flush cannula, because here, for example, the surgeon is dealing with the vitreous and also lasering as got the view. And now this is what I wanted to talk about, is have faith in your back flush cannula. It just might be a simple thing you do with the back flush cannula, might make your life easy, and you can see that there's not a big thing to deal with. So you can wash it, flush it, and then carry on with the rest of the vitrectomy. So to put it in literally to summarize it, as Mustafa said, know where you're going. The ABC of basics in vitrectomy should be applied, like a couple of extra tips, and be patient. Always tips available, infusion line in its place, and deal with what you need to deal now, and then most of the time, like further treatment might be needed outside the theater, because what you need is to clear the vitreous hemorrhage, to be able either to get to know the diagnosis exactly, or to prepare the patient for a second phase of treatment. Thank you.
Hussein, thank you so much.
That's
That was really
amazing.
fantastic. So, Mohammed, I'll get your presentation here. If you can set up any questions, any work, any suggestions? All right. Okay. So we know now. Hussein told us what to do, and Dr. Kenan is now going to tell us what not to do.
Do you see my slide?
Yes, sir.
Yes.
Yeah. Is it full screen now?
It's full screen. Yes.
Yeah.
Okay, so I'm just going to tell you what to do. First, I'm going to talk about the lens. You know that the starting vitreoretinal photos have pay a little respect to the lens, and there are different ways of touching the lens. You can touch the lens with the light pipe, and you can touch it with the cutter. I'm going to first show a sign, the lens flare. It's usually when your lens flare is basically.
I'm sorry, can I interrupt you for a second? I think the voice is not clear. If you can come a little bit nearer, and we're all going to mute to make your voice clear.
So, okay, do you hear it? Is it clearer now? Is it clearer now?
Much better.
Yes, it is. Yes.
Okay, so the lens flare is basically when the light goes scattering through the lens or flaring through the lens, and it's a warning sign that the light pipe is close to the lens and you need to back away from the lens, otherwise you're going to hit the lens. So this is, hold on. So this is a case here to demonstrate that, yeah, don't touch the lens. Yeah, don't touch it. So you can see here, this flaring through the lens, this is this is a lens flare. It's a warning sign that the light pipe is close to the lens and you need to go a little bit back. Another way here, you can see the flaring and the glaring effect of the light pipe when you're close to the lens. When you see that, you need to recognize this sign and you need to get away from the lens of the light pipe. I'm going to show you here. This is how the light pipe should be. There shouldn't be any glaring. This is a safe distance of the light pipe from the lens. And you can see here another flare again, and you can get away 1 or 2 times, but eventually, if you keep doing this, you're going to end up with having a lens touch like here. It's visible clearly. You can see the light pipe imprinting on the back surface of the lens here. And zooming in, you can see it here very clearly. So this usually happens when you don't pay attention to your light pipe and you keep focusing on your cutter. So you need to pay attention to this sign and act accordingly. So this is a more serious case where you touch the lens with the cutter. This is a case of a dense vitreous hemorrhage. You can see the red reflex is very dim. It's almost black. And the fellow here, there's something wrong happening and the fellow is not recognizing. And you can see that the eye is collapsing, but the fellow failed to recognize that. And the next thing you can see that the cutter have actually cut the lens. And in this case, we actually started the case without turning on the infusion. And my tip to you is just to turn on the infusion before starting in every case. Usually when you have that, you have a lot of experience, you have a mix of emotion. At first, you have a denial, this didn't happen, it didn't happen. And then you start to realize, yeah, it did happen. And then you start to cry, think about different ways of getting yourself in that stage, find solutions. So I'll ask the panel here, what do you guys do when you have this complication? You guys hear me?
So Hussein, what do you do?
Yeah.
No, I'm not. Can you hear me now?
Yes. So we have 2 things. We have lens touch,
yeah,
and then we have lens munch.
I mean, to be honest, with the lens touch, it depends on how much touch you've done and how much and how is the view. If I think my thing to do is, if you're able to carry on with your surgery with that view, don't hesitate in carrying on, and don't try to go back and try to do the cataract as part of it. So even most of the time, even if the central view is not good, you can still rely and finish your surgery on the peripheral view, which is nice and great, and leave the cataract for a future surgery. Now, when it comes to munching the lens, this is, I think it's something different. And in this case, it's like, you have no options, so you need to deal with it. But I think a lens touch is something that central view, if it's bad, you can rely on the peripheral. Moving the eye upside, up and down, right and left, you can manage to deal with the rest of your surgery.
Yeah, I do exactly like Hussein. Any different view, just for...
Sometimes the lens, when you munch the lens, sometimes just the peripheral nibble. Sometimes you can go through the surgery without doing any cataract. But in the case, just Mohammed showed, actually there is a central big
yes.
lens. So in that situation, I think you'll need to remove the lens.
Yes.
The situation is that you have a pre-planned biometry or no? This is the question.
No.
Yeah, this is a tricky situation.
Yeah. So what do you do? You have a
biometry routinely for all vitrectomies, all phakic vitrectomies. Some hospitals do that, but some don't. Especially in vitreous hemorrhage, it will be a bit tricky to calculate the lens power.
Yeah. We don't do that. So, so if you don't have a biometry for this case, what would you do? Would you just right away remove the lens, or would you take out the anterior and the posterior capsule? You take the whole lens out. What would you do?
I think it would. Sorry, go ahead.
Yeah, please go ahead. Please go.
Okay, I mean, I was just gonna move quicker for the sake of time. Again, I think you try to spare as much as you can, even spare some of the posterior capsule. You can come back and put the lens in the bag if you have a good posterior support or sulcus. And I think leaving the patient aphakic is fine, really. And then coming back and putting a lens. If you have to take everything out, I would just take everything out. I think for retina, you don't think about the lens. You know, you want to preserve it, but you really need to move on.
Okay, so I'm just going to go on with the case here. So what we wanted to do is just finish as much possible into playing. Is it playing at your side?
No, I think it's it kabooted.
A set of loading or something.
Okay, hold on.
Okay, maybe until Mohammed sort that out. I think a good question really is, other than not using PCs and using Mac in the future, a good question again from Riley is where do you put the ports? So question to Hussein. So Hussein, you said based on the ultrasound, you may move the infusion cannula, maybe like from infratemporal to infranasal. Right? There's a colloidal detachment, or yeah.
And I mean, to be honest, I mean, it's designed to be inferior for. I mean, if you can do it infratemporal, do it infranasal. But I've seen. I mean, I've been with cases where we sometimes had to put the infusion line even superiorly.
Yeah.
So try to keep it inferiorly. But because when you go superior, it's going to interfere with the rest of your hand movement. So it's all about making sure that whatever decision you make, that you're not making your life more difficult.
Yeah. The other point three are you back, Mohammed? Okay.
Yes.
The other points are the trocar reposition. So I think Mohammed said 3 and 9. We usually put them more up like this, so more like 10 and 1 or 10 and 2, and we can touch on that again because that's actually an important point. Mohammed, go ahead, please.
Do you see my presentation?
Yes.
Okay. Okay, so we continued on the case just to clear some blood to have a good reflex when we and you can see here there's this is the lens munch there. We just take the trocar out and use the MVR. Yeah, just there's some blood in the anterior chamber. This is a good thing that you actually you have to do a little punctures in the posterior give an easy access to the lens matter with the fragmentome. We're here fragging the lens out. And in this case, we don't take the anterior capsule out. We try to preserve the anterior capsule for, like a secondary implantation later on. And this is a very nice trick here. We use the light pipe to visualize the epithelial cells while scrapping it. We're scrapping it away from the center to give the patient some vision to help you prevent opacification in this area. And we conclude the case about this. Another area, another time where you can actually touch the lens is when you try to clear the blood clotted at the vitreous base. You go more anterior, and then the next thing is you're hitting the lens. I'm going to show you this is something irrelevant here, but you can see here the cutter is facing the retina, and this is wrong. You should have the cutter facing the opposite way around. So basically, yeah. So in phakic patient, you have to keep in mind that. Hello? There's a little hissing sound. You guys?
Let's all mute.
You hear me?
Let's all mute.
Okay, so in phakic patients, you have to keep in mind that you're gonna end up leaving some blood inside the eye, and it's okay. It's peripheral. Won't affect the vision and will absorb after some time. You don't have to go crazy after the last drop of blood in these phakic patients, because once you go more anterior to the, like pores rata, a little bit into the pars plana, that's fine, but don't go far beyond, because the next thing you're gonna hit the lens. This is another instance where you can hit the lens, where you can get bubble behind the eye, behind the lens. I'm going to show you a thing here. Look at this bubble. And yeah, don't do that. Because one time you can judge it well and you're going to get this lens, you're going to get the bubble out. But the other time you're going to hit the lens. When you have multiple bubbles, it's and then you can go from outside, vent the trocar with the blade, and you can see the air here comes out nicely and very safely, and you don't have to endanger the lens this way. I don't have it here on the on video, but I can show you. There's this. You can see here some bubbles, and the way you can actually take the bubble safely is to tilt the eye toward the trocar and have the trocar in a superior position, and then you just take the cutter out so that it's barely inside the eye, and keep cutting. You don't vacuum in this area because there's vitreous in there, and you keep going in and out until the air is out. And this is also a safe way of doing it. I'm done with this.
Mohammed, the bubble is gonna go. You're tipping the eye down. Is the bubble gonna go towards down or towards up?
So basically, you have the trocar rotate the eye so that the trocar is superior.
Yes.
So that the air bubble usually is superior.
I think he should rotate it the other way. I think it should be rotated the other way in this diagram. Like have the cutter on the upper side, right?
Yeah. So that's it. The upper side. Yeah, you're correct.
So this is a great tip. I really did not know this. This is a fantastic tip, and it's always easier to in phakic patient to remove the air while the lens. You can do it like with the microscope without the biome lens. So that's a great tip as well.
Yeah, and as Ahmed is like as Mustafa said, it's preventable. So make sure that your infusion line, that you literally prime it well, so as to avoid having those bubbles. Exactly. At the beginning. So it's like
sometimes you can get regurg of air from the cutter, even if you clear the infusion very well. Sometimes the cutter can give you some regurg of air. It happens.
Yeah.
So can you please get the macular hole, your macular hole up, as we can get on, and if you can, just go on your doctor tips. 1.3 is just one last point. The trocar, if you get the trocar 3 and 9, this is fantastic for reaching up. But the problem, especially if you're doing macular work, there's a torque happens. Everyone has his own sweet spot, and this happens really when you have a fellow starting and they put the trocars and you find yourself struggling. So that's just an important point. Just see where you want your trocars. The other last point is what Mohammed said about don't go crazy about removing inferior blood. It's just good to understand. Removing the inferior blood decreases the, in diabetics, risk of early post-operative bleeding, because usually it leaches from there. But if you are to hit the lens, then don't do this. Abdullah, please go ahead.
Oh, should I start? Yeah. So I'll touch quickly macular hole. Yeah, so in the UK, actually, we do nearly a vitreomacular interface surgery once a week, either macular hole or retinal membrane. And macular hole, actually, we believe it's a simple surgery. So we try to focus on small details. So in our case, we do cataract surgery for most cases with macular hole, because we are planning to put gas in, which most likely to cause cataract. So most of the cases we do the cataract combined, either 25 or 27. For all trainees, I recommend to be a bit meticulous with removing all the viscoelastic in front and behind the lens as much as you can, and not to do any wound hydration. Usually the AC forms quickly. I like to coat the cornea with viscoat, and I normally change it only once during the surgery. And as mentioned earlier, make sure the infusion is well connected. Oh. For the surgery, I usually do very simple central core vitrectomy as quickly as possible. And I prefer to go do a little bit of trimming close to the disc as well. And nowadays, I do dye-assisted BVD induction for most cases. I found it very useful, and it's often preferable if you can induce BVD if there's no one under visualization, because I'm intending to induce very gentle BVD. And I usually do it on 2 steps. Initially, trim a little bit, and then engage the disc. Once I engage the disc, sorry, yeah. So then I engage the disc, start to induce the BVD here. I don't go all the way around. So I go back again, trim a little bit more vitreous, and then try to induce the BVD in another part. In this way, I'm doing very minimal traction on the retina as possible. And I go with the BVD a little bit by bit. I usually don't go behind the equator. And I don't normally trim the periphery of the gel at this stage. And now then I move quickly to put the dye for the peel itself. I like to dribble the dye, as you have seen here, so I have good concentration of the dye on the macula. Again, remove the dye quickly and go to the peel stage. It's always good to remove the dye as much as you can, because this will improve the view for yourself later on. For the peel itself, I'll stop the video here. I try always to do one pinch for the peel. So the first pinch is the most important. And the tips here for the beginner, when you use the forceps, try to make the tips very close, so very narrow openings of the tips, so you engage very minimal tissue when you pinch it. And one more tip to consider is that the retinal thickness, let's say 0.5 millimeter thickness or 400 micron at this point, usually the shadow of the forceps, you need to be a little bit before the forceps itself come close to the shadow. Leave about 400 micron thickness, which is the thickness of the retina. And also for the new starters, it's good to do few pinches before going on the eye limb itself. This will make you a good feel when you start it.
So Abdallah means few pinches in the air.
In the air, yes.
Yeah,
yes.
So pinch in the air, and then get to the retina and get approximate more closed than open.
Yeah. Yeah. And as you have seen here, I made a bench in the eye limb, and you can see it's atraumatic bench. Try to be atraumatic as much as you can. And once that, I catch from the edges. So most of this technically demanding step is the bench. Later on, just follow the edge. And as you have seen here, I started on the temporal aspect, superior temporal or inferior temporal, but try not to start close to the babellomacular bundle or close to vessels. And here, re-gripping from the edge, all the time from the edge. So I have done only one bench in the eye limb peel. Sometimes the eye limb peel is friable, but it's okay. Go again, grip from the edge. And I like it to be as slow as possible, because sometimes you have seen some people do it very quickly. This sometimes causes damage to the nerve fiber layer, what we call dissociation of the nerve fiber layer. You can see. And the next step is to make sure that the eye limb is cleared all around. I normally aim for about 3 to 4 millimeter peel around the macula. And that's it. Then I go to the periphery. I'll show another case of peel, very simple. Again, when you put the dye, just drip it. Don't gush or don't force it. Just let it dribble over the macular surface. So by this way, the dye will be concentrated over the macula. You want the dye to stay in the macula, not the peripheral retina. And then go very small, forceps closed, nearly closed, small bench, and you have seen I got the bench now. Then I start again from the edges and follow it all around I normally do that in stages, step by step. There is no rush because I try to induce very minimal traction over the retinal fiber layer. And also for new starters or new fellows, make sure there is some curvature of the eye, because sometimes in the early stages, while you are using the forceps, you may hit the retina inadvertently. Sometimes also when you peel, the peel stops and there's still some attachment to the disc, to the fovea. So make sure you remove the eye limb all around the fovea as much as you can. This is important. This helps to improve the success rate. You can see still small attachment. I'll remove it shortly. And that's done. You can see a good peel around 3 to 4 millimeter. I'll skip this one. Okay. Oh, sorry. And then I go trim the peripheral gel. I do very minimal peripheral trimming. In macular hole surgery or epiretinal membrane, the pathology is in the macula. So you don't need to do meticulous peripheral trimming. You need to be very gentle with the peripheral vitreous. Try to avoid making any breaks. And after that, I do a peripheral search. And just make sure, like any vitreous surgery, you need to check the periphery carefully to rule out any breaks or any other retinal pathology. And you may have seen here still some vitreous here, still in the periphery. Just tell you that I didn't trim all the peripheral vitreous. I just very gentle with trimming. Yes. Should I touch on the gas concentration?
I think, Abdullah, if you want to touch just quickly in a minute or two, and then we can move on.
One of the important aspects of the success of the macular hole surgery is putting the gas correctly. And the simplest way to dilute the gas is to make it on a 50 ml syringe. So I usually, let's say you are looking for a 20% concentration. So we connect it to a 3-way tap. Take a little bit more than you want, and then push out till you reach the 10 ml mark. And then withdraw the air till you reach the 50. So now you have 20% concentration. Close the 3-way tap, and that's it. So you have a gas 20% concentration. And after that, getting the correct concentration, I connect it to the infusion. You have two options: either do it now or remove the 2 superior trocars and vent with a needle. I prefer to vent with a needle in most situations. I prefer to remove these trocars, make sure that sclerotomies are nicely sealed. Usually they seal well with 25 gauge vitrectomy. And then my left hand is injecting the gas, and my right hand with a small 30 gauge or 28 gauge or 27 gauge needle is venting. And the good thing about the 50 ml syringe is that you flush the eye at least 7 or 8 times. This makes sure that you have a good concentration of gas inside the eye. There are 3 options for gas. In our practice, we prefer C2F6, which stays about 4 weeks. Some people prefer SF6. Minority of people prefer C3F8. I don't feel there is a big difference, whichever gas you use. This is the point I touched before. Sometimes larger peel is not an advantage. Actually, some results show that macular hole closure rate is similar if you do a smaller peel, about 3 millimeter, compared to a larger peel, 5 millimeter. And also the visual outcomes seems to be better with a smaller peel. Posture, does it make a difference? Actually, most holes close in the first 72 hours. More than 90% of holes close in the first 3 days. Therefore, gas fill at 72 hours is actually more important than the type of the gas you put. And there is a debate about whether face posture is needed or not. most people believe that it's mainly needed for large holes. This is a good tip from a recent data from the large UK study about the macular hole, that one of the main reasons for failure is that incomplete eye limb peeling. So if you have incomplete eye limb peeling, you have about 17% chance of failure. But if it's complete, the chance of failure is only 4%. The good thing about macular hole is usually the results in most cases are predictable. If you have a good outcome, you see good restoration of the outer retina, you see nice foveal depression, and you can see restoration of the external limiting membrane and the ellipsoid zone. This is also one favorable outcome with good restoration of the foveal architecture. This one is a good restoration, but you can see here there are irregularities here on the inner surface. And it's a common thing actually you often see after macular hole surgery or any surgery with eye limb peel, is what we call dissociation of the nerve fiber layer. And it has been shown that to be correlated a little bit with decreased retinal sensitivity in these areas. One more aspect of the closure of the macular hole is sometimes you get inner closure of the inner retinal layers, and you get this gap or delayed closure of the outer retina, which is what we call foveal lucency. And we studied that before, and it's usually not a problem. And we found that eyes treated with C3F8 have lower rate of lucency compared to other gases. Yeah, I can stop here for the sake.
Okay, Abdullah, that's great. So again, I think the message really for routine macular hole is ILM peel and just do the least required. Always do internal search. And Abdullah showed the classic way for doing the gas. You don't need to inject the gas yourself. I mean, Abdullah likes to do that, but in the beginning, it's best not to do this yourself. You have the assistant injecting the gas, and you're just venting, whether you vent through a vent or through a needle. So, Mohammed, you have some tips of how to do? Yeah. Abdullah, go ahead, as Mohammed is loading.
For people in other countries, if they do any flaps for primary idiopathic macular hole in the primary surgery? Mustafa?
No, really. Like it's very unpopular here in Canada to do like ILM flaps for primary macular hole. Typically, we do just a standard classic complete ILM peel. Size is like 3-4 millimeters, as you said, and the success rate is really high that you don't really have a concern. Like it's very uncommon, and usually if it doesn't close, there is another issue, like chronic hole was neglected for a long time, or very large, or another issue.
What type of gas you use, Mustafa? SF6?
SF6. I believe that just as Abdullah mentioned, that actually most holes actually close in the first 72 hours. So you don't really need a long-acting gas. It's not going to do you any good. You need a gas that just lasts long enough for the first few days only.
I mean, we did a study. We looked at SF6 versus C2F6 and C3F8, and there was no difference. But yeah, that's great. Mohammed, do you have any what not to do?
Yeah, for the sake of time, I'm just gonna go very quickly over what not to do during ILM peel. So basically, don't start your peel at the PM bundle. You can see here a surgeon is trying to peel the first one from all spots in the macula. He chooses the PM bundle to initiate his peel. This is wrong. You shouldn't do this. I'll show you another video where the surgeon is also trying to peel, trying to initiate his peel in the PM bundle, and you can see there is a lot of deep grasp there, and you can see the blood. Initiating the peel is the most traumatizing step of ILM peeling, so don't do it in the PM bundle. This is another case where the surgeon is trying to peel. He starts peel first at a blood vessel. This is doing. Don't for a blood vessel. It can bleed, and So these are the spots that you shouldn't be peeling on: the PM bundle, over the blood vessels, and of course, I don't have to talk about the fovea. You don't start your peel over the fovea. You have all that area here, like on the temporal, on the superior temporal and infratemporal area, and you can also in this temporal area also you can pinch anywhere you like, wherever you have access, whether you were left-handed or right-handed. This is another case. This is another thing that you shouldn't be doing. I'll show you here that the surgeon is going very close with his light pipe to the retina. Light toxicity is real.
Mohammed, you're cutting. Your voice is getting interrupted. I think we may have lost you as well. Well, I think just to summarize, the points Mohammed said are actually very important. Don't go for the pupil and macular bundle. Don't go for the blood.
When I started my fellowship, I used to have this problem all the time. I used to have a good focus, and once I go in again, and then once I reach over for the retina,
Okay.
The eye down while you're reaching with your forceps for the surface of the retina, and instead of sliding the forceps through the trocar, you're actually pushing the trocar and the eye downward, so you lose your focus. That's all my text not to do about IOL reading.
Okay, Mohammed, you were interrupted in some points, but I'll summarize.
Okay.
The important points Mohammed mentioned is that don't peel in the pupillomacular bundle over a blood vessel or fovea. The other very important point, sometimes you lose the view, especially when you're very anxious and you're very wary of your hands and you're pushing down on the eye as he showed. So ease off a little bit, and with experience you can ease off. The other bit I just want to say, the least traumatic is to pinch with the forceps, but that can be a little bit difficult in the beginning. So even using a diamond cutter or a finesse loop in the beginning is fine, but then once you get experience, move on to pinch with the forceps. But whatever you can do in the beginning to make life easy is very good.
Any suggestions about for like new surgeons is like contact lens use?
That's a very important point, Hussein. So what do we all do? So, Wael, you're going to say something?
I mean, to be honest, well, please go ahead.
I actually use a macular contact lens. It provides me with a super view. It enables me to do whatever technique I would like to adapt, whether to do a stroke, to elicit a snap. The contact lens is wonderful for the macular surgery. I think when using the contact lens, you can avoid a lot of the do's and don'ts that you think when you use the biome or any non-contact lens system. And another point, if you use the chandelier as an illumination, even in macular surgery, I think this provides you with an unprecedented chance that both hands are ready. Sometimes you need to stabilize. You can say it very easily. You need to do the steps slowly. You can do it extremely slowly with a great deal of dexterity. When you stabilize, sometimes with your left hand, the instrument that you are holding, the forceps that you're holding with right hand. And so this helps you. It makes life easier, even though you will use much more tools than usual classical. This is
Well, you're a bit interrupting, so I mean, I think just.
Well,
so I think your point is a chandelier.
Yes, chandelier and contact lens.
Yeah, you're right. So contact lens and chandelier. Just be wary. I mean, if you're starting surgeon, controlling your chandelier with your hand is tricky. So again, but as you move on, that's a very nice way, and Wael does that beautifully. And I'm sure he will show us some videos when he's talking on lenses. So anyone uses anything other than a contact lens? So Hussein, do you use a contact lens, or what do you use?
I to be honest, I mean, my favorite is to use the biome lens, which is the magnifying lens, the macular lens. But to be honest, as I agree with Wael that sometimes when I feel that the view is not adequate for me, I go into the contact lens and I get a great view. But one thing about the contact lens is that just because of the use is that the field width is smaller, and you need to make sure that when you go under a contact lens, it's a more constructed field of view. So you need to make sure that the tips are always visible, because the movement, it's like it's going to be any movement. If it's more than what you need, it would have a significant effect compared to the macular. So that's one of the things that the view is great, but the field is restricted.
This is a very great point. So the view is much better with a contact lens, but any sort of a magnifying lens, even the biome lens, the green or the 90 or the green lens for the Zeiss, has a restricted view. So what you want to do is to go in the eye, see the instrument first, and then go down.
Yeah.
Try to go down straight, and it happened to me. I hit the retina. So go in the eye, see the instruments, then down. Mustafa, do you use anything different? Just to answer.
I use flat lens most of the time. The contact lens most of the time. It gives like excellent magnification and depth. But sometimes I use the non-contact biome lens, the regular one. I found the green lens to be very hard to adjust my depth of focus when I use it. I tried it, but I couldn't really use it. But I prefer the contact lens most of the time.
And Abdullah, you said you use the biome lens, right? Yeah.
Yeah, we use the IBOS, so we have the high mag lens. I normally change. I start the surgery with the high mag lens, doing the core vitrectomy and central vitreous, and then move to the beal. And after that, I change from the high mag to the low magnification lens to do the peripheral trimming and such.
Right. Yeah. Thank you so much. Well, get ready. I got your presentation up here if you want to get ready.
Yes.
So again, I use the flat lens, but I work now with 3D, and with the 3D, I can use just the high magnification lens of the ReSight. But if I'm not using 3D, I would use the flat lens. There's advantage and disadvantage to contact versus non-contact, as we all know. So just be wary. A very good point, 3D. And macular hole is a simple surgery, so let's keep it simple.
Yeah.
And well, when you get we cannot see your presentation yet.
Okay.
All right. Yes. Go ahead, please. So now moving on from the macula to the lens, and Well again is going to show us a simple way to remove lenses.
Well, this is the point where the posterior segment and the anterior segment meet. Very simply, I will be very practical in my approach. I would like to tell you what's our target. Our target is to remove the IOL that has been dislocated and to look for the subsequent management, whether we would reposition it again, which is very rarely successful, or to implant another IOL that is secure enough not to dislocate again later on. One of the important factors that govern our decision is to identify whether there is a sufficient capsular rim or not. And then we go to the technique. Here in this case, there is a sufficient capsular rim. So I go directly into the vitreous cavity, a setting of vitreoretinal surgery. I do a meticulous core vitrectomy, and I try to manage the posterior hyaloid before I retrieve the IOL. I usually look at the step of the retrieval of the IOL as almost the final step in the posterior segment before I go back to the anterior segment. I usually like to start peeling the posterior hyaloid without staining, without a triamcinolone or any stain. When it goes smoothly in my hands, I do not inject, and then I use a forceps, end gripping forceps, to grasp the lens and to take it to the anterior segment. In the anterior segment, I need to make sure that I remove the lens from the dangerous area to the a part above the capsule or the iris. And so I hold with one hand the lens and try to stabilize with a spatula or another forceps from underneath until I am sure through the capsular opening, the capsular rhexis, that I have my lens completely removed from the posterior segment into a safe area. After that, I plan the explantation of this IOL. An IOL that drops one time will drop every time. I explant the IOL, and in this case, it would be very simple to implant a 3-piece IOL in the sulcus, because this sulcus, as you see here, is sufficient. We have a 360 degrees sulcus, so I can manage by simply implanting a 3-piece IOL, and then I close the wound. Of course, the priority is not for a sutureless wound or something like this. We seek to explant the IOL safely and to implant a new IOL that replaces this one. Well, when there is an insufficient capsule, like in this case, this is actually a tilted or a subluxated IOL within the capsular bag. I usually remind you again that we need to have the setting of a vitreoretinal surgery, even if we are managing a simple anterior segment maneuver. Before I try to explant this IOL and bag, I prefer to stabilize and to make sure that the lens, there is, to explant the IOL within the bag slowly to avoid as possible as I can vitreous traction, especially in the periphery, in the aura cerat. And after explanting the IOL and the bag, once there is sufficient iris and no capsule, the main choice for a vitreoretinal surgeon, or for me as a vitreoretinal, is to implant an iris flow lens, a retropupillary iris flow lens. I consider this the easiest, the simplest, and the least traumatic. I will demonstrate it later now in a group of videos. Sometimes.
Well, let me just ask you one question here. I like the way you supported the lens. This is very nice idea. Maybe, I mean, would you put Kenalog beforehand and try to make sure there's no vitreous around it, or it's difficult to, even if you do this? Because that's what I do. I put Kenalog and then we cut, and then, but then I don't support the lens. So would you put Kenalog and cut as well beforehand, or?
I agree with you, but sometimes I feel that I can visualize, I can out-visualize the vitreous in that area. And sometimes when I see it, I will demonstrate now, shortly, another video where I cut off the zonules myself in an area that was subluxated. But let me continue with this. This is sometimes another pathology that you may find in the posterior segment that would make your IOL retrieval a little bit lengthy. In this case, it was a diabetic eye with a combined fibrovascular tissue here and a branch retinal artery occlusion. And when I injected triamcinolone, I found that there is a recalcitrant layer of posterior hyaloid. So I had to keep the IOL aside and to ignore the presence of the IOL without, of course, shaking the IOL. And I tried to peel the posterior hyaloid as possible as I can and the fibrous tissue as possible as I can. And at a point during the peel, when I found that the IOL may interfere with the completion of the posterior hyaloid, I had to hold it. We may hold it with one hand, and this is maybe one of the advantages of having a chandelier illumination, and to continue the peeling of the posterior hyaloid with the other hand until I feel safe and satisfied with the hyaloid peel, and then I would go up anteriorly with the IOL after that. So in this case, the priority was to finish up with the posterior segment before the retrieval of the IOL, and after getting the IOL into the anterior segment and explanting the IOL. Of course, this is a single piece IOL. it is very difficult to attempt to reposition this IOL again. I finished the posterior segment maneuvers. Even under air, we can implant an iris flow lens securely and simply.
Well, can I just can I ask the panel here? So in a situation like this, so have the hyaloid intact and difficult to complete the hyaloid without moving the lens, would you, Hussein, would you take the lens out and then go back and complete the hyaloid separation, or you would hold it like this? And I would like you to put yourself in the shoes of a new surgeon or a novice surgeon.
I think, I mean, for an experienced surgeon, I mean, this is possibly a good point to be done, which is remove the lens. But I mean, I myself am going to advise somebody to do something is just get to the back, possibly release. I mean, do the vitrectomy part. I mean, you will have enough view so as to deal with the back of the eye, because even with a dislocated IOL, we could still have good view. And then after that vitrectomy part, mainly the core vitrectomy, you could get back and remove the lens and then carry on. So possibly release the adhesions first and then, you know, explant the IOL. This is how I feel I would do it.
Yeah, no, different way to do things. And Mustafa, would you again, would you hold lens or try to move it more to the side, or you would remove the lens and go back to the hyaloid?
I would try to work around the lens as much as I can, but if I wouldn't, like if I really I'm completely unable to complete my job in the presence of the lens, I would just make sure that I cut all the adhesions around the lens, and the lens, only the lens is completely free from the gel, and I can then remove it and go back to the posterior segment.
And Abdallah, would you do like Wael or like Mustafa?
In non-diabetics, I usually trim the whole vitreous and then bring the lens to the front. Actually, in the case where shown in diabetics, actually most of the diabetics, after removing the vitreous, and if you put triamcinolone, you will get this second layer over the retina. So it's a very common phenomenon. So my feeling, I prefer if I removed all the vitreous, removed all the traction around the lens, I can take the lens out and then remove this second layer of vitreous attached to the retina.
And Mohammed, what would you do?
I think I would do like Mustafa. I would try to, you know, like induce the PVD, but if I find it very difficult in the presence of the lens, then I will clear the vitreous around the lens and I'll take the lens out, and then we'll deal with the vitreous afterwards.
Okay, well, I personally may do like Wael, but if I'm in the shoes of a new surgeon, I will do the same as well. Remove the hyaloid and come and sort it out later. Well, great surgery. Carry on, please.
Okay. This is another situation.
Click hide for this StreamYard.
Here, where can you press hide?
Okay.
Thank you, sir.
Oh.
Sorry. Yeah, here you go.
This is a situation, subluxated intraocular lens in a phimotic capsular bag. I demonstrated here under high magnification. You see the zonules, even though the zonules are there. I am sure now there is no vitreous in the AC. But still, to explant this IOL safely, I prefer to manage this, to cut the zonules yourself and still stabilizing from underneath as possible as I can. I enter with the probe. Of course, I cut the zonules without the risk and to take care not to cut the iris. I need this iris for the subsequent iris flow lens implantation. And when I am sure that a lot of the connections were released, I can now just pull on the IOL in the bag, and with the protection from underneath, I can explant the IOL in the bag. And once this is done, again, we face the situation. We have a complete intact iris without a capsular rim, and so we go on to implant a retropupillary iris close. Another situation that we may face is, okay, we are now managing a dislocated or subluxated IOL, but with an underlying attached retina. It is a simple procedure. What if there is an underlying retinal detachment? In this situation, for example, whenever there is a tilted IOL or a dislocated IOL, this is I try to relocate, not to retrieve. I want to relocate the IOL in this situation in the anterior segment, in the anterior chamber above the iris, and to keep it in this part until I can manipulate, do all the posterior segment manipulations, and then at the end, I would rather in this situation, and this is my preference, to explant the IOL and not to think to postpone about the secondary IOL implantation until a second stage when I am sure that the retinal work has been completely accomplished and that the targets were achieved. For example, in retinal detachment, to make sure that the retina was sustainably reattached, for example, under silicone oil, and then when I'm sure that the procedure, the next procedure, which is silicone oil removal, will be just a simple silicone oil removal with an attached retina, I can then at that time plan a secondary IOL implantation. I mean, in this situation, the priority is for the management of the retinal detachment, and I postpone the secondary IOL implantation to a next stage when I'm sure the retina is okay. I will show you some tips shortly about the implantation of an iris glow lens because this is my preference. I manage this part even if the surgery is a secondary IOL implantation. I insert a complete vitreoretinal setting, trocars including the chandelier, and I make sure that any residual capsule that is impractical and insufficient, I remove this. And then I work inside to check whether there is a posterior hyaloid detachment or not, and then proceed with the implantation. The priority is to have a simple, accessible incision through which I can implant the lens. I have two choices. We have two choices, the clear corneal incision and the scleral tunnel incision. Scleral tunnel looks attractive from the point of a refractive point, less astigmatism, less number of sutures. But actually there is a risk in the presence of an infusion line to develop an iris prolapse, which may make your implantation a little bit challenging. The second point, there is an important point in the iris glow lenses, the orientation, because it is a concavo-convex lens. We need to make the concavity of the lens anterior and the convexity posterior. And this is one of the causes or the important things in the implantation, because we want to enclave, we want to enclave the iris in this defect in the haptics. So we need to make it the highest points of the lens, so the concave surface is up. During the implantation, we enter with this orientation because this is the least wound depth, wound diameter for this, and then we rotate the IOL, reduce the infusion pressure, and go down under the iris, and then through 1 or 2 MBR incisions, we start the enclavation. I usually go through 1. I go to the distal part to enclave first, the distal one, yes, and then to the proximal one, and to enclave using a spatula. I don't use special instruments. Another point here, we don't need peripheral iridectomy because the lens surface was concave anteriorly, so there is a defect which enables the aqueous to flow. And then we close the corneal incision, whether with a figure of 8 or a couple or 3 interrupted sutures, or more, according to the preference and of the surgeon. These are the final tips for an iris glow lens, and this is the end of my demonstration.
Thank you so much. This is fantastic. Abdullah has a different way of doing it, and you can see this in the course that we did on dropped IOL and aphakia. Again, for the new starters, anti-chamber IOL in cases with cornea is good, iris is good, angle is good, is fine. Just keep it easy. later on, if you can really do artisan or aqueous scleral fixation lens or other lenses, fine. But I would keep it easy at the beginning. And remember, these are all surgeons who have been practicing for many years. But at the beginning, just keep it easy. And if you can do artisan, fantastic. It's a great lens. Thank you so much, Wael, for this great presentation. So any final comment on lenses Right.
We can't hear you, Abdullah.
Abdullah is trying to say something. So I'll load the presentation on retinal detachment. And
one comment. Wael, the case you showed where the lens capsule was completely fibrosed and the lens becomes subluxated, where you had to trim around. I like a lot the technique you did, that you tried to remove the whole lens in one part. Because I came across a case like that recently, and I tried to cut the lens into 2 halves and remove them. Actually, I ended up with a lot of fiddle and manipulation, and sometimes the easiest and the simplest is the best way. Just trim around it and remove it as a whole. It's actually a very good technique.
Thank you.
Yeah, large incision, especially as you're starting, I wouldn't really worry much about astigmatism. Large incision is fine. Get the job done. As you're becoming more experienced, you can cut the lens in. But keep things simple. And remember Mr. Hussein Al-Muhtasib saying, don't fiddle.
There is another point about refractive surprises. Wael mentioned about the concavity and the convexity, which is great. And the other thing is the A constant of the lens when you put the biometry parameters. So the retropupillary has an A constant different from if you're going to implant it in anterior to the iris. So, many things. I mean, to be honest, it's a great choice, Wael, about the retropupillary. One thing I'm not sure about is to do or not to do a peripheral iridotomy. That's one of the things that
I normally do for all these cases peripheral iridectomy, either with the cutter if it's combined with vitrectomy or with scissors. Some other opinion like Wael, they said it's usually not needed because the lens is convex and it's unlikely to have chafing between the lens and the iris. But my feeling is that it's safe to do and very easy to do. I often try to be safe as much as possible.
I have a case, and hopefully one day we will show it to you guys. I've done bilateral retropupillary artisan. In one I did a peripheral iridotomy, and the other one I didn't do a peripheral iridotomy. My plan was to do an anterior segment OCT to see how the eye looks like and how the iris.
Very nice.
This all happened just in beginning of March, just before the COVID. The patient will be coming hopefully in 2 weeks' time, and I'll do this, and hopefully we will share it.
So please update us.
Yeah, that's a great
please
idea.
share it. Yeah.
Okay, we'll move now to retinal detachment, and then if we have time, we'd like to touch quickly on endophthalmitis. But retinal detachment, and please feel all the panel feel free to interrupt and cut off. I'll just say a few bits here. The general idea, food for thought, and I work now in the US, but I trained in the UK, so I do like the guys train here in the UK. So I do try to do the minimum required. So for the cases who are young patients with retinal holes, like this one, or a dialysis, no PVD detachment for me is a buckle. It's just a straight-on buckle, and that's how we were trained. It's just much, much easier. This is a patient where I did not listen to the advice I'm giving you, and I did a vitrectomy because I thought she had PVD. And really, that's the problem. Other than the lens is going to go cataractus, it's very difficult to separate the hyaloid. And there are different ways. One way is to use a pick. Sorry, I do apologize. And you'll find more on the pick on the Facebook page and how the pick can be helpful. And here I initiated the hyaloid separation with the pick, and now it's easier to do with the cutter. But to start off, this case should have been just buckled. Then The other thing I do use, again, I always use Kenalog, although there's usually vitreous separation. Some cases, like this lady who was myopic, have vitreous chiasis. So I routinely use some Kenalog just to make life easy for myself in retinal detachment surgery vitrectomy. The other thing which I would strongly advise is this concept really. Look at this patient. This is a patient who had a retinal break that was partially lasered, and he had retinal detachment from that break. So now I'm under air absorbing or drying the fluid from the break. So the break is dry, and one way to know that the break is dry is that you can see really the choroid very well at the edges, and that the break is really adherent to the retina or adherent to the retina. So now I'm moving to the disc, and there's already subretinal fluid, and see what happens here. As you move to the disc, now the fluid under the retina is heavier because there's air inside the eye, so it all pulls backward. So this is a situation you need to anticipate, whether you're going to do a drainage retinotomy or you avoid going to the disc and have an underfill, that's all fine. But you need to understand as you move to the disc, the fluid shifts down. And in this case, I did a drainage retinotomy because I worried that there's too much fluid that may cause a macular fold. It's not about the detachment, it's about the retinal displacement. But again, have a thought about it. And that here we're saying is, as you move to the disc, the fluid goes back. So either you want to avoid that or do a retinotomy, or most important, positioning, avoid the patient sitting up because that fluid may go even more central and you get a fold in the retina. And that's a case here, courtesy of Dr. Taufi, where there's actually the patient starting on with the retinal folding. And this is a very nice concept here, where if you look, there's a shadow for the retinal blood vessel here, and a shadow for the retinal blood vessel here. That's after the surgery. And the retina actually is displaced. The retina was displaced beforehand in this case, but the gas can displace the retina as well. So something just to be wary of. And that's here the original blood vessel position. So again, just have a thought about that. The other thing, I don't do any macular work unless there is a reason. Like here, there's a retinal detachment with a macular hole. Then I will do ILM peel. Or there's an epiretinal membrane, then I would do epiretinal membrane peel. So these are the points really that I do. I like, as most of us said, identify non-PPV detachment and do a buckle for them. Retinal break surgery, you just manage the break. Focal retinopexy, no 360 laser, no extensive work, and gas, and be wary of the retinal displacement. So any questions or any thoughts from the panel?
Yeah, one comment. For cases where you are not 100% sure whether there is a BVD or not, you can do, using the OCT, you can do the circle scan or high quality line scan through the disc. And if you have the facility of, for example, if you use the spectralis, you can do the vitreous visualization mode. You'll be able to see if there is a BVD or there is some attachment, and you may be also able to judge it's like a strong attachment or weak attachment.
Right, that's a great point. So now what I want to show you, I do two things. If the retinal detachment due to an upper break, for me that's a slightly different surgery from if the retinal detachment is due to lower break. And I'll show you the difference. Here, this is a retinal detachment in a phakic patient. So I'm doing the same thing that Mustafa said. So I move with the cutter working more on the periphery here, the phakic patient, so working on that side, and the cross point is a line going through the fovea. That's the cross point. If you crest any more, you can touch. Then here, this is the break here, and then in the other side, you can go on until you shake hand with the other instrument as long as you're peripheral. So my first step is to remove the vitreous, and then switch hand, and then remove the remaining vitreous. This is a phakic patient. So remember the cross point. So here I'm actually crossing even more. You can touch with the shaft at that point. And I cross hand and go to the other side, which usually I don't do except in retinal detachment because I want to remove more vitreous and remove the traction. And here I'm indenting with a finger, but that's, again, you can get someone to indent for you or use a chandelier if you want, and relaxing over the break. Okay, so now this is the vitrectomy part. The second part is the most important part, which is the internal search. And what I'm trying to do with the internal search is to search the retina very systematically. I put some canalogue to look for vitreous, but there was not really much. And now it just starting from 12 to 6 o'clock, and I'm indenting the retina on one side and then the other side. Usually I start with the attached side first. And I found actually a break here that you will see more in a minute in an attached retina. And now I indent on the other side, and we know that there's a break here. So take your time. This is the most important step of the surgery. Now this is for the break. Yeah. Sorry, that's the break in attached retina. So I decided I always get rid of that and I don't mark it. I just treat it before putting any gas in the eye. So that's done. And I just cry this break. Now I'm going to go and flatten the retina. I mark the break with the diathermy, and always do that, even if you're a very good surgeon, at least in the beginning. So you don't want to go back and remove the air and try to find the break. Then draining from the break, and this is the point where Mustafa said, faith, the view gets better. Just faith. And then here, it's dry as much as I can, but there's lots of retinal fluid under the retina, as you can see. Now, cryo comes in. And again, done. And then make sure you cover the horns, but don't over cryo. And then this is the situation now. There's a lot of fluid under the retina. But in my mind, this is an upper break, really. And even if I get a 50% gas fill, that's enough. Because going to the disc, I will get the fluid pulled more backward, and I'll have more retinal displacement. That's what's going in my mind. So I decided, fine, this is next day. We got the patient next day, and that's the fill. So it's about 50% gas fill, but that's enough for an upper break. And that's the patient here after 1 week. And that's the autofluorescence, and there's no displacement. So that's what I do for upper break retinal detachment surgery. Do you do anything different, gentlemen?
No, I do exactly the same. The one thing I do a bit more is that I ask these patients to stay on the back for 2 or 3 hours after the surgery.
That's exactly what we did. And I think I'll try when they stay on the back, and then I'll try to image them even before sending them home.
Yeah.
Yeah,
please go ahead.
Well, do you do anything different?
Yes.
The same?
Yes, I like to use the fluorocarbon liquid.
Okay.
And to spend some time during the PFCL air exchange at the interface, at the bridge level, so that I feel more safe concerning the residual retinal fluid in the posterior.
Right.
I will have, many times you will still have some residual fluid, subretinal fluid, but it's a quantitative estimation.
Yeah. So where you use PFCL routinely with detachments?
Whenever the breaks are peripheral, yes.
Whenever the breaks are peripheral.
Yes, but if there is a relatively posterior break, no. I drain through it with the direct fluid edge.
Yeah. And Hussein, you do the same, right? We were talking about that.
Yeah, I think we agree regarding not to use PFCL due to the risk of toxicity, and also to have the pumping action of the retinal pigment epithelium is good enough. so as to, especially in macular off detachments, so as to get rid of the fluid. And I think we discussed that before. Is when you do the fluid air exchange and you see the fluid is seeping closer to the arcades, you might just leave a bit like what we call like a puddle of subretinal fluid. Sorry, not subretinal, a puddle of fluid between the gas and the surface of the retina, and this might theoretically reduce the chance of having retinal folds or displacements. So, I think the eye is able to sort itself out once you close the tap, which is when you switch off the tap, when you treat your brakes.
Great. Okay, Mustafa and Mohammed, I'll ask you, what do you do after this case? So this is really what I do when I have the detachment due to inferior brakes. And in my mind, I need a bigger gas fill. I cannot do 60% gas fill. So here, this is the case. I have 2 brakes, and it's a chronic detachment with a subretinal band going through the fovea. You may see it here, but I really decided to leave it. It's just away from the brakes, and removing it is going to be a big hassle. So I decided to leave it. The subretinal band. Again, listening to my friend, Dr. Muhtasib, less is more, and don't fill it. So, all right. So here, draining from the brakes, thinking I might get a good fill. But then I found out what you'd expect. The brakes are so peripheral, and there's lots of fluid. So here I wanted to get a better gas fill, so I decided to do a drainage retinotomy. So usually I mark it with the diathermy, then I poke it with the diathermy tip, and then I complete it with the back flush. And then here the back flush, and then you can see the retina is getting flat, and the edges of the tear that we've made is now stuck on the RPE, and that's my endpoint when the edges are stuck there. And now in my mind, now I have the retina flat, so I'll get a better gas fill, and then laser to. So the tip here is to keep it dry, get the laser ready, and then quickly laser the posterior drainage retinotomy, because that will, and I lasered it here, because that will collect fluid so quick. And then you laser the peripheral brakes, and then you have a bigger gas fill. So that's what I do for inferior detachment. In my mind, I actually need a better gas fill. So I would drain, or I would use perfluorocarbon liquid. I try to avoid perfluorocarbon liquid, and I do a drainage retinotomy. So Mustafa, do you do anything different?
No, actually, I agree with what you do. I tend to do much less with retinal detachments. I started to make it even more simple, although I already used to make it simple. But like, I'm not really very keen on shaving the vitreous base everywhere. Like, it's a matter of treating the breaks. If I know exactly where are the breaks and I treat the breaks, I really feel comfortable with it. I agree with you with superior breaks. I'm not worried at all about having some retained subretinal fluid. I trust, like, even with the half filling of the gas, you still get rid of the rest of the fluid easily with the positioning. With inferior breaks, I'm very keen on drying the retina, get the maximum fill I can, and usually use longer lasting gas like C3F8. And typically I'm successful to drain most of the fluid, like adequately drain with tilting the globe and making the break the most dependent part. Usually it works. If it doesn't work, I don't shy from doing posterior retinotomy. I like posterior retinotomy. It makes life easy, and you can finish the surgery really in short time without much fiddling or worrying about using PFCL and removing PFCL and worried about retained PFCL and so forth. But I use it PFCL if I have to, but I use more posterior retinotomies. I feel it makes the surgery much shorter.
Right. Hannah, do you do anything different? Thank you, Mustafa. Do you do anything different?
No, I think it's basically the same. I probably, what's that?
No, go ahead.
Sorry. We didn't use the PFO in a primary detachment in my fellowship, and except like in 2 cases throughout the fellowship, and we get like 20 cases of detachment per week. So yeah, PFO for us for giant break and retinectomies, and PVR detachment. But for primary detachment, we never use PFO. For inferior breaks like this, I try to drain from the rake like you did, and if there is like significant subretinal fluid, I'll do retinotomy, posterior retinotomy like you did. So yeah, it's the same thing as you do.
Yeah, I think my sincere advice for starting fellows and young people is really do it simple. At some point when you're comfortable, definitely for some time use PFCL just to be familiar with PFCL. It's also an art using it, but then go back and, as I would suggest, try not to use it. That's what I would do, and that's what I do with my fellows is that I teach them how to use PFCL, and we do several cases with it, and then we stop using it, except for giant break and retinectomy, similar to what Mohammed was saying. That's the UK classic teaching. All right. Any other final comments on retinal detachment?
Yeah, one tip for in inferior breaks. Actually, I do exactly the same like what you mentioned. One of the tips is that when you try to remove the fluid from the inferior tear, especially if the tear is very peripheral, sometimes it's difficult to remove all the fluid, but at least you try to do as much as you can. One of the tips is do it passively. So passively is a bit slower and actually may take a lot of time, but
longer.
It's actually helps to enter as much fluid as you can. But if you end up with a pool of fluid under the macula, drainage retinotomy will do well in the situation.
So one point to just emphasize, if you leave fluid under the retina, it's not about the detachment is not going to work. It's about a smaller gas fill and the risk of displacement. But then if you are forcing the retina attached with gas, that's again risk of displacement. Just a few things to think of.
Yes, and one thing in that situation also, I ask the patient to stay on the back for 2 or 3 hours, just staying on the back, in their back. So hopefully that will help the RBE bump to clear some of the fluid. Unfortunately, we don't have information about the rate of RBE, how it works. But the good thing on putting the patient on the back, this will make the gas on the peripheral retina in contact in the area with the tear. Hopefully, this will help drying it out. And laser works a bit better than cryo for these cases.
Yeah, so again, that's my point. For inferior breaks, I try to laser. For superior breaks, I try to cryo because of what you're saying. Well, are you strict with any positioning after the surgery, direct after the surgery, for the sake of this retinal displacement, or your?
Yes, I usually put them on face down position for 4 hours, and then semi-sitting position during the day, and after that during sleep, to sleep in a position where the break is uppermost.
But face down, you get them to sit up then face down, because the problem is the sit up, I think. So,
I have seen Professor Eckert in Germany. He usually personal communication and observation with him, that it is a routine for him to keep the patients face down for 4 hours. He believes that the initial 4 hours are the most important, the critical hours for the breaks to close and for residual subretinal fluids to be pumped out by the artery. And when I implemented this strategy as a routine in these cases, I found out that, well, he is right.
no, I
Just
mean,
4 hours
for example,
I don't need more than this.
No, I mean, when, for example, the patient now is like, whether under local or general, they are on their back, right?
Yes.
So to get them face down, they sit up and then they go face down.
Yes.
In the sort of like the displacement, the issue is that when they just sit up, then you may get a displacement at that point, even for a minute.
This is one of the most important instructions that we give to the patient. When we say the word rest, it is not just a rest for the body. It is a rest for the head and rest for the eye.
No, but when they are on the operating room, right, you allow them to sit up, or you would like get them to roll in the bed and go face down, because that's the critical point, is when they sit up, for example, if they're recovering from anesthesia.
Yes, you're right. Through the bed itself, after the surgery is
Yes,
off,
yes.
it's elevated.
Yeah, it's just a thought. Really. I don't know. It's a thought.
Hmm?
It's a thought. That's why in the UK they roll the patient,
Yes.
and you hear about the slug roll, and it's just a thought.
But I would like to tell you something. I think we are giving this issue a greater weight because during the surgery, once the break is closed, sealed, and the labor is performed, and the gas is properly filling the vitreous cavity, I don't give a great role for the mobility and how it happens uh, as a transition from supine to a face down position.
Right.
I think Dr. Kalam, the point you say about keeping the patient lying down on his back or like rolling him on the bed, that's only applicable if you have a stretcher that goes in the OR and then you take the stretcher out to the recovery period. But if you don't have that and the patient has to move, like walk out to the OR or you have like in a wheelchair, that's a totally different scenario. So I think face down would be much more feasible in this situation.
Right. Okay. Again,
Actually,
so Mustafa, you may want to speak to that and maybe highlight the last paper from Toronto for the audience, and we can close with that.
no, actually, I want to say something else.
Yeah.
I do roll every single patient of detachment on face down on the surgical table immediately after I finish the surgery, and they stay like this for the whole recovery time. I have two thoughts. There is some echo if there's some echo if we just can mute for just a second. Yeah. So there's two things here I'm thinking about. One issue is retinal displacement, and the other issue is formation of macular folds, like true folds. So retinal displacement is something that decreases the quality of vision after fixing a retinal detachment. But folds is a real big issue. Like you really need to reoperate again if you have a true fold. So my thought, theoretically, or I believe there is no one solid answer for this question at this moment, and discussions can keep going over this like forever. But I believe you, or who like you, and who else agrees with you about keeping the patient supine has better chance of avoiding displacement because you leave the job for the RPE to pump the subretinal fluid, and this will have theoretically the best chance of really returning the retina in the exact same location and avoiding displacement. But I feel that there is also a risk if you still have fluid. The presence of fluid actually has some risk of developing a fold. So for me, I would sacrifice displacement and I position the patient face down immediately so that I have almost a zero risk of having a fold, because you basically reattach the retina even if there is some little displacement, but the retina is flat and you will never get a fold because the macula is already flat. So that's why this is my philosophy now, and I'm not sure if I know there is room to make it better in future, but I don't know when and how. Like I keep monitoring what's being done.
I think what you said, Mustafa, is important, and the thing is with displacement, when they compared pneumatic with vitrectomy, like in terms of displacement, yes, vitrectomy was associated with more displacement, but in the end, at 1 year follow-up, the metamorphopsia and all these problems with displacement was not different between the two procedures. So yes, displacement can happen, but on the long run, the effect of displacement, maybe like the brain somehow correct for that. So maybe worrying about it that much is not the right thing to do.
I think these are actually a great point, and the retina wants to go back to its position. Anyway, I think there's a great paper really in JAMA this year from Toronto. It would be really nice if someone wants to look at it, or if the audience wants to look at it. It's just an interesting discussion on positioning. And with that, we can finish the session. I think we'll leave endophthalmitis to another time. Any final comments or word of wisdom from the panel? We start with Hussein. Hussein, any final word of wisdom?
No, to be honest, I mean it's been a great experience. To be honest, I learned a lot of more extra tips to use. Even I mean, at the end, it's an ongoing learning process. We're learning from each other. We're learning from our mistakes, and it's been a great experience, really.
And Abdullah, any word of wisdom?
Yeah, thank you very much. It was really interesting. And I think the main concept is that, especially for new starters, actually less is more. The less you do, actually, the better results you will get. And to be minimalistic, sometimes extra maneuvers, unless really necessary, may have affect the outcome. Thank you.
And Dr. Nubi, for any tips or final word of wisdom from Asyut?
Yeah, I think that, perfect is the enemy of good. So yeah, fiddling around, trying to make things perfect, sometimes, like you pay a penalty for this. So you just want to get in, do the job, and then get out. That's basically keeping things simple. That's basically the message.
Okay, well, thank you, Dr. Mohammed. We read on the Facebook that Asyut is better than Toronto, even, right? We all read that on the
That's
Facebook.
true. That's true. Yeah.
Okay, Mustafa, you trained in Toronto, not in Asyut, but that's fine. Any word of wisdom?
I wish I could complete my training in Asyut, maybe. But another word of gratefulness, actually. Thank you so much for having me with you guys. I really enjoyed being there and honored to be with you. And it's rather a word of gratefulness rather than wisdom. You guys said all that stuff.
Right, thank you. And Wael, any final word of wisdom?
Oh,
Wael, you're muted. Wael, you're muted. You're muted.
The first thing is that I enjoy being with you all. You are all fantastic, and you have mentioned everything. But one point is to spend some time for a proper decision making for the surgery and a proper planning, as Said mentioned in the beginning of the webinar. The plan, the proper decision making, makes things easier. That's it.
Okay, well, finally, thank you so much, all of you, and it was really great. I've learned actually great tips, and I'm very grateful for your time, and I hope that our audience as well learned a lot. My advice to the audience is, again, less is more, and also please try to look at videos, look at the Facebook pages, YouTube. If there's a surgeon near to you, go and visit and see what they do, see their flow. And that's how you become an efficient surgeon. And also apply what you do for cataract surgery. We all try to be more efficient for cataract surgery. We do the same as well for retinal surgery. Right. Well, thank you so much all, and goodbye.
Thank you so very much. Take care, guys.